Good day everyone. I am Michael, moderator for this webinar. I welcome everyone for today's webinar, which is CMS Hospital Improvement Final Rules, Nursing Medical Records, Infection Control and Antibiotic Stewardship Program, Restraints, QAPI, and more. It's a great pleasure for me to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon, PS, JD-RN, CPHRM, served as the Director, Facility, Patient Safety and Risk Management and Operation for QAPI from 2014 to 2020. In her role, Ms. Dixon provided patient safety and risk management consulting and training to facilities, practitioners, and staff in multiple states. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Michael, for that very nice introduction. I do appreciate it. So as Michael mentioned, what we're talking about today is the Hospital Improvement Rule. And actually, that wasn't the name they gave it to it. That was sort of the compilation of the rule, just to make it shorter. And so it was very all-encompassing. Just for some ideas here, this is what the final improvement looked like. It was over 500 pages long and was very encompassing. So the manual itself, this is the rule. This is what hospitals have to know and abide by. Staying current, I always recommend you subscribe to the Federal Register. That will keep you updated and you'll get notices of when things change. The operations manual, this is for Appendix A, and it's the same for the Critical Access Hospital Manual. So what were the changes? These are the sections that changed and what we're going to address today. What they wanted to do with is just to make sure the hospitals are following the standards of practice. The overall benefits, why did they opt to review and revise the conditions? So I want to start with the QAPI program, patient care data. The board has to make sure each and every hospital meets all of the requirements. This is a big task. On QAPI for critical access, I did include kind of the crosswalk for the C tags. As far as your data collection, now these are just some of my suggestions, smaller changes that they made. First off, for psych hospitals, I mentioned they added the conditions right into Appendix A. Well, what about patient rights and non-discrimination? This is a second question. Which gender identity? So what CMS proposed? They want to put together a non-discrimination rules. All right, if I don't see any questions in the chat box, feel free to enter them. I will address them at the time. Otherwise, as Michael, the moderator, said, we will address those at the conclusion of the program. So as far as the PA ordering it, they also covered in the restraint seclusion the 1-hour face-to-face exam that has to be done. Again, violent, self-destructive patient. For PAs ordering restraints, all right, seeing no questions, I'm going to move on to emergency preparedness. H&P for healthy outpatients. This was a gift to hospitals. If you're going to do this, yes, you need a policy and procedure. What they found was that we got almost 29 million ambulatory surgeries. Ambulatory surgery centers, there are some subgroups that may benefit still from having a full H&P. Your bylaws have to probably be amended so that they can adapt for this. As far as acute hospitals, another one I want to talk about is the laboratory look-back program. Nursing services, there was a little bit more expansion. Also immediately available, it's required for every patient. Some CNOs didn't know. They had to do an annual evaluation to make sure this was done. Especially on agency nurse, they also clarified the outpatient RN when you're looking at those outpatient services. Another component of nursing, surprisingly, was drugs and biologicals. You need an order for all medications, with the exception that clarified verbal orders. Medical staff autopsy, this is a very, very short section. Swing bed changes. First big change, dental services. Activity program. Another one was a social worker. This is a third major change that they implemented. And then the fourth change. What if you have somebody who's in your swing bed? I'm going to pause here and go over to infection prevention and control, an outpatient setting. This was included. Infection control and outpatient setting. So if you have clinics, surgery centers, maybe you're doing dialysis centers, your infection prevention, control, and antibiotic stewardship program. That's a mouthful, and unfortunately that's the way it is. Antibiotic stewardship program. Health and Human Services, they put together an action plan on it. So the new requirement, what they did was we want to make sure hospitals follow our nationally recognized. So you must have, for your antibiotic stewardship program, you also have to have a preventionist. We used to call this the infection control nurse. We want to control those infections that are coming in, or maybe we're sending patients back out to, say, care facility. There were changes to the worksheet. I mentioned those before. I mentioned training for your infection preventionists. You can also do it for periodic or annual infection control training. Active antibiotic stewardship program. They are really stressing this. As far as infection control, what do they have to do? They have to put together the program. Now, the board isn't exempt from what they have to do. They have to communicate, collaborate with QAPI. Those core elements, they were updated in November of 19. This is the antibiotic stewardship program that I talked about, and there's even one core elements for small hospitals and critical access. So as far as a system-wide infection prevention and control, Joint Commission, I just want to mention this real quickly. It's as a reference only. Governing body, they appoint the person who's going to be over it. They're qualified. So as we start to wind down, I want to go to critical access hospitals. As far as staffing and credentialing and privileging, as far as overall, for critical access hospital, the board assumes full legal responsibility. QAPI, so as we come to a close here, I've already talked about your high volume, high risk areas. Take credit and document those projects. Use your data to monitor effectiveness. Thank everyone for attending and hanging in there and listening. The hospital improvement rule was meant to make our life a little easier. Hopefully this was helpful to you. Again, use those worksheets to your advantage. That will definitely help. And again, next week there will be a presentation on restraint and seclusion. That is a very highly cited area within the manual itself. So thank you, Michael, and I will turn it back to you to close us out.
Thank you, Laura. So that does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead. Bye-bye.